Greetings from Digital Team Indian Medical Association. I am Dr. K. Agarwal, National President IMA and also President Heart Care Foundation of India. With me, Dr. V.K. Monga, the Honorary Finance Secretary, Indian Medical Association. Welcome to our weekly show every Thursday, 3 to 4 p.m. And for the last many weeks, we are trying to focus on national health programs of the country. And we thought this time we will cover antenatal care, some aspects of neonatal care, adolescent care, child care, and also, of course, 10th of February every year is a deworming day. We will talk about deworming, what to do, what not to do on that particular day. With me, I have two experts today. Dr. Anjali Kempe, she is Head of Department and Director Professor of Obstetrics and Gynecology at Maulana Azad Medical College. My senior from my university, that is Nagpur University, GMC Nagpur. I belong to Sevagram and GIMS, and I was 1 year junior to her. So, inko mere kaan pakadne ka hak hai. And I have with me Dr. Ajay Khera. He is a DGO and then MD in Public Health. So, he is a public health expert. He is currently Deputy Commissioner and in charge Child and Adolescent Health, Ministry of Health and Family Welfare. And his focus has been MCH, mother and child care. All his years, for the last 25 years, he is in the ministry. We can't have a better person than him to talk about various government programs, including a deworming program for tomorrow. Starting again from Ajay, you two. Start with you. When I go to mother and child, what are the different national programs as on today which are happening?
Basically, mother and child is a very, very high priority program for Government of India. And you must have seen that, mother and child health programs, they have come in, different names. It used to be called as the, child safety program, child survival program, CSSM program. Now, presently, what we are talking about, mother and child health program as a RMECH program. RMECH. That means reproductive, maternal, newborn, child and adolescent health program. That means if you really want to improve the health of the mother and children, you have to use the life cycle approach. That means unless you address the health of adolescent, your mother's health cannot be improved. And if the mother's health cannot be addressed, the newborn health cannot be improved. So it has to be a complete package and it has to be a life cycle approach. So the kind of the program which we are talking in the country today is called as the RMNCHA program. Now within the RMNCHA program, there are different limbs. Now there is one limb which is called as the maternal limb, then there is called as the newborn limb, then there is a child health limb, then there is adolescent health program. So these are the broad 4 limbs of the program. Now all these limbs have different strategies, different interventions. Suppose I start with, let's say, adolescent health. Now within adolescent health, the components are, although to be very frank, it will take maybe 1 hour to explain what is that adolescent health program. But for the purpose of, let's say, the private doctors, the general practitioner, there is something called as the weekly iron and folic acid supplementation. Now this is the program which is being implemented by Government of India, and the rationale and the background is because 50 to 60% of the adolescent girls and boys in the country are found to be anemic. This is the data which says, and this has been there for the last 20 years. If you look at those data sets which have been done independently in the surveys, it shows very high prevalence of anemia in the country. Actually, the whole country is anemic, and we may not be realizing. That's why we say every adolescent, because if 60% means every alternate. So as a public health program, what we have proposed is that every adolescent girl must receive weekly dose of iron and folic acid supplementation. And we are making sure that schools are participating, and the results show that the coverages are quite satisfactory, around 30 to 40% of the adolescents in the school and even the out of school adolescents are being covered. So this is one kind of intervention for you to know. And maybe the same thing should be implemented while you are as a practicing doctor, that once you come across you should not look for anemia actually. Any adolescent girl comes, a kind of a preventive weekly supplementation can be given. And I think in a similar tone, I also know, as a doctor, that generally, we wait for anemic child to come and mother come and tell your child is, looks pale. In an ideal situation, in a program mode, what we are saying is every child must be given prophylactic iron and folic acid, and which is there in the program. Like for adolescent, we made it weekly for the purpose of improving compliance. But for the purpose of children, small children, we say at least 100 days in a year, every child must get that iron folic acid supplementation. And those syrups are available free of cost, and they are available at the nearest health center. And maybe I think if IMA takes a lead, because anemia is a huge issue. And we have not been able to make any dent in anemia for the last many years. I think anemia across the life cycle, whether it is adolescent, whether it is pregnant woman, whether it is child, all across the board. And I think if the support of the local doctors, the private doctors is there, we'll be able to address anemia in the country. So that's one part of it. Now the second thing which is being done under the MCH program is, beside giving iron folic acid supplementation, we are also promoting identifying high risk mother.
I'll go. Let me know, once you have taken iron, let's finish up iron. You say that in pregnancy, what is that?
Our women are actually not having an access, that is a problem.
In pregnancy, daily iron?
Daily iron, 100 milligram.
100
It's a
milligram, how much
elemental iron every day.
So 100 milligram
That's a
daily.
prophylactic dose. Prophylactic dose.
Yes.
That is from second trimester. First trimester, they may not tolerate that. And if it is patient is anemic, then it can be doubled.
Okay, that's okay. So I'm talking about basically campaign is C, that in children, 100 days a year.
In a year,
100 days.
every child must get.
Okay.
From 6 months to.
No, I'm going to come back. And then we're talking about adolescent, we're talking about weekly, 52 in a year. And then do we have anything for adults?
Yeah, particularly for women, we have weekly iron supplementation. Even
what's the definition of anemia? 12.5 or something?
No, that's not. I'm not going into. I'm going into a public health campaign.
Yeah, that's the point.
My public health campaign was the good chana khao. Always.
Yes.
Traditional was good chana. Always iron chana is 14. And Santoshi Maa ka Vrat, once in a week good chana. And good chana was our traditional. Traditional, our good chana has been going into our basic sciences. Good chana. So good chana khao. If you can't, iron folic acid khao.
ये भी बात है.
ठीक है, क्योंकि good is महंगा, iron is cheaper. Iron is free, good is costlier. इसलिए iron folic acid khao.
What I would say is they are not calorie wise also. The women particularly, whether they are pregnant or not pregnant, they don't have the calories also, enough calories.
चना में आ जाएगा ना, तो गुड़ चना होगा तो चने में कैलोरीज आ जाती है, प्रोटीन आ जाता है, कैलोरीज आ जाती है, इसलिए गुड़ चना का उसके साथ में जो है गुड़ में कैलोरीज भी आ जाती हैं उसके साथ में. But I'm going to come back is that when you talk about children, we have in adult we have a formula of 80. 80 दिन धूप में बैठो, 80 दिन ये करो, 80 दिन ये करो. I'll come back later. तो 80 दिन करते हैं इसको. इस साल में 80 दिन गुड़ आयरन खिलाओ 100 के बदले.
कर सकते हो. आई थिंक बेसिकली
यूनिफॉर्म हो जाता है ना, यानी याद करने की जरूरत नहीं है कैसे.
मैं इस बात को ना इसलिए रेस कर रहा हूं.
Why only children? हम कह रहे हैं children. You are saying adolescent में you are talking about 52. Why? In adolescent also 80 बार कर देते हैं कि आप बच्चे हो रहे हो 80 बार हाल में. So 80 times in a year.
They have fixed one day.
वो प्रैक्टिकल फिजिबिलिटी के लिए है.
मैं प्राइवेट सेक्टर की बात कर रहा हूँ.
बिल्कुल.
आपका एक प्रोग्राम है प्राइवेट सेक्टर में, कैसे याद कराऊंगा किसी को भी.
80 में जब 10 दिन नहीं भी 10 बार नहीं भी खाएगा ना, बावन बात में एक
हम बात कर रहे हैं ना कि आप साल में 80 बार अनाज मत खाओ, साल में 80 दिन धूप में बैठो. जो फार्मूला मिट्टी बना रखा है हम लोग जो स्प्रेड कर रहे हैं उसमें फिर ये 152 तो अलग अलग हो गए. या तो बहुत
गवर्नमेंट प्रोग्राम
जरूर होगा. अगर हम
इसमें मेरे
ये कोई डे फिक्स है कि आपका?
कुछ फिक्स नहीं है ऐसा.
अगर कोई डे फिक्स है कि आपका आयरन के लिए?
नहीं, स्कूलों में कई स्टेट्स ने फिक्स किए हुए हैं इसके. बट दीज आर ऑपरेशनल फिजिबिलिटीज. होता क्या 2 महीने की छुट्टियां हो जाती हैं बच्चों को, उन दिनों वीकली नहीं मिलेगा ऑफिस. तो दो जाती है इश्यूज. But you can create your own system. The purpose here is that preventive iron and folic acid.
We'll come out with some campaign on iron. We'll campaign on some campaign on iron folic acid. And in ANC we are talking about
minimum 100 into 100 days. You can make
minimum
it
100.
minimum.
100 milligram, 100
200
days.
days.
That becomes better then.
Yeah,
If I want to change from 80, then it has to be 100 milligram, 100 days.
at least. It
Yes.
should be actually.
Then under 100.
For
That can be
smooth sugar
the
also, then you can make it 50 then, at least 50 times in a year, at least.
adolescent dose is 100 milligram बच्चों में, वहाँ पे 160 milligram.
उसकी डोज ज़्यादा है मुझे लगता है. I won't be able to tell you, but there's a weekly dose.
We'll come out with some
I can share that in a
some things will come out. And so we are not bothered about checking, we are talking about prophylactic dose. Everybody.
The reason being because prevalence is more than 60%. इसीलिए मतलब हम इसलिए कर रहे हैं ना, प्रिवेंटिव दे रहे हैं. और and even if you look at the available diet which people are taking, because many people are vegetarian in the country.
Weekly iron
और
is not
हमारा
going to
iron
harm.
consumption काफी कम है.
Weekly iron.
Variety of reasons, I don't
Weekly
know.
iron is not going to harm.
Yes.
ठीक है? तो क्या आपने अपनी आयरन फॉलिक एसिड वीकली डोज खाई क्या? स्कैन पे निकाल देते हैं.
यदि मेरी जो अपनी पर्सनल ओपिनियन होगी, यदि IMA मेक्स इट काइंड ऑफ कि आयरन फॉलिक एसिड सबको देना है जो भी उनके पास आएगा. Suppose you are reaching, let's say 2 million people, I don't know, there must be some magic number. Then you must be reaching. कितना है? जो भी होगा.
20 million at least.
So if you say whenever they come in contact with any IMA doctor, private, you should make sure that iron folic acid is advised and can suggested. It can make a real major difference actually in the anemia scenario in the country.
ठीक है. Now next point. One is pregnancy is nothing more than that.
It should be actually more than 50% women need anyway
We are
therapy.
putting on universal. Today we are, unless there is nothing, we are talking about universal point.
Right.
कि everybody has to be given iron folic acid. Number 2.
दूसरा जो important बात है, particularly in terms of MCH program, the identifying high risk mother. Because 90% are normal pregnancies, but the art of a MBBS doctor is to identify high risk mothers. Now, in order to identify high risk mothers, there are very very clear cut pointers. Number one, particular blood pressure, which is very common. One has to measure blood pressure, and if the BP is very high, accordingly the medication has to be given. And second is multiple pregnancies or twin pregnancies or hydramnios. I mean, as an MBBS doctor, one can always suspect, and in order to suspect, the simple principle is you just keep on recording the weight of the mother. Generally, I find that people are not tuned to measuring weight and trying to make a decision. Because generally we expect this much weight has to be happen every month, but suddenly the mother gets the weight is very very, she gains the weight. Then one has to suspect multiple pregnancies or maybe hydramnios, and then accordingly investigation can be done. And luckily now we have a big program of the government of India, that Pradhan Mantri PMSME program, where on 9th of every month, every mother is to be kind of tested properly. And even there is a provision to conduct a free ultrasound, free blood test of that mother. So basically identifying number one, blood pressure. Secondly, by examining, try to find out through the weight recording and examination some abnormal pregnancy. And then the third could be like identifying severe anemia. Because initially we spoke about general anemia, severe anemia. She is severely pale, she is dyspneic, kind of a thing, 4 or 5 gram hemoglobin. So she needs to be intervention has to be done immediately. And then there are kind of procedures in terms of injectable iron and so on and so forth. So that is the third. And then obviously tetanus toxoid vaccination has to be ensured. And iron folic acid tablet has to be given routinely. And then the calcium supplementation is another intervention, which is generally being talked about in private sector, but even now in the Government of India program, there is a kind of calcium supplements are proposed.
So, madam, regarding this program, IMA क्या करता है हम बता देते हैं इसमें. IMA करता है 99999. ये 9 की बात कर रहे हैं, हम 99999 की बात कर रहे हैं. कि हर 9 तारीख को 9 महीने के लिए हर प्रेग्नेंट लेडीज में 9 रिस्क फैक्टर्स देखो.
गुड, वेरी गुड.
9 रिस्क फैक्टर्स देखो. 9वें महीने में पीडियाट्रिशियन को इन्वॉल्व कर दो ब्रेस्ट फीडिंग के लिए, और 9 महीने तक बच्चे का सेक्स डिटरमिन ना करो.
ठीक है.
ये हमारा 99999 को हमने इस ढंग से हम लागू तक ले जा रहे हैं. 99999 बच्चे का सेक्स पता नहीं करना, 9 महीने तक जो है इसको ये रिस्क फैक्टर्स बनाए हमने, नो रिस्क फैक्टर्स, जीरो फैक्टर के हिसाब से नो रिस्क फैक्टर, न्यूट्रिशन भी आ गया, यूरिन एल्बुमिन भी आ गया, टॉक्सीमिया भी आ गया, अल्ट्रासाउंड भी आ गया उसके साथ में, और 9 तारीख को 9 महीने के लिए
मुझे कुछ समय से the maternal mortality which is still quite high in India is mainly because of 3-4 things, out of which one is hemorrhage. So hemorrhage indirectly means anemia and hemorrhage later on. So we have taken that part into account. Second is hypertension. Third is septicemia, sepsis. These are the biggest causes. After which other causes come like medical disorders. So septicemia is one big cause which has not been looked into. So in addition to his saying that iron supplementation and other things, detection of high risk from low risk. So third factor I was saying was septicemia. Septicemia could be due to anything, home delivery se leke, it could be abortion, septic abortion. So this factor has not been controlled at all. So the private practitioner, in addition to looking into blood pressure and anemia, which he can detect easily, any general practitioner would always remember that the patient who is not having access to health in any way will come to that person first time with fever or signs of vaginal discharge, post-abortal, or any other medical disorder which is not controlled, and then landing up in abortion, in septicemia. So either antenatal or postpartum septicemia is a big cause even now, and post-abortal also. So this, in addition to what you have said, has to be looked into.
So let's go hypertension. GP क्या करे, कितने पे क्या दे?
First of all, they should look into the history of the patient. Then they should extremes of ages below 18, below 20 years, and above 35 years, the woman is high risk in any case. If she has any history of previous cesarean or any history of surgery in the past or mishap in the previous history like any abortions or IUDs or stillbirths or neonatal deaths in the earlier pregnancy. So history wise, these points, 4-5 points are important, that whether she had a bad outcome earlier, secondly whether she had any medical disorder, that's another cause of mortality which is not controlled. So history wise, these 4-5 outcome, obstetric outcome, whether it was bad earlier, extremes of ages, and then like I said, control of medical disorder, whatever it was, diabetes, hypertension or anemia. These 3 are killers in our country mainly. So these have to be controlled, and then only she should undertake.
GP level पे BP किस level के BP में क्या दवाई पे और कब रेफर करें?
ये generally patient को आप 5वें महीने में बुलाइए. After 20 weeks, any time BP high is labeled as preeclampsia or hypertension during pregnancy. Earlier, it will be better if she comes in the first trimester. Ideally, first
what is the
trimester.
level? At what level?
140/90.
140/90.
Systolic 140.
So
and that's
140/90 के ऊपर में हमें कंसल्ट करना है.
बिल्कुल.
And what is the drug which a GP can give?
Safest is Aldomet, but then you don't start it. I think if BP high, this comes to a specialist. This patient
Goes to a gynae.
Yeah, at least at 2 different times, BP exceeding 140/90 on 2 different occasions with half an hour rest to the patient. Patient just coming in and you take BP, it could be high. She has to rest for half an hour and then take BP.
So any 140/90 is our cutoff value. Then you refer at a high risk.
Yeah.
And if GP is a female gynecologist, MBBS who is practicing gynecology, then Aldomet is
Safest is Aldomet.
safest. Amlodipine.
Amlodipine and other things, I think a gynecologist should prescribe. But if the access is not there, then they can start.
So
But,
this becomes his hemoglobin we have taken care of, blood pressure.
Labetalol is better. I would say.
GP नहीं करेगा.
Labetalol
I know,
instead
GP
of
नहीं करेगा.
amlodipine. Instead of amlodipine, I would say.
So Aldomet or Labetalol.
Aldomet at his first referral level.
And
But
out
we
of
don't
100,
start.
how many will have high BP? More than 140/90.
Out of 100 women?
Out of 100 pregnancy.
Which is 5 to 15% is
5
the
to
incidence.
15%.
5 to 15%.
of A and C will have high BP.
Yes.
Sepsis कैसे बचाना है?
Septicemia, I think home deliveries are the reason, one. Second is unsafe abortions.
ये कैसे बचाना है?
बचाना कैसे और
कैसे पहचानना कैसे?
पहचानना ऐसे है कि पहले तो हिस्ट्री होम डिलीवरी तो शी इज लाइकली टू हैव सेप्सिस.
Fever and discharge.
Antibiotics, yes.
So fever and discharge.
Fever and discharge mainly.
And with high TLC.
Anemia obviously.
And high TLC.
Yes.
High TLC.
Yes.
And what is the drug which can be given at the level of a GP?
Any antibiotic like simple ampicillin से लेके we use ampicillin because patient is breastfeeding or something.
Amoxicillin.
Amoxicillin, this group, yes, will suffice for the to start with. And then of course the cultures, vaginal swab cultures and blood culture. And history of abortion they don't reveal at all. You must ask whether patient had amenorrhea 2 months, 3 months, and then she's coming. She will not generally tell you that she has had an instrumentation. She will also not tell you that Dai has seen her from
So
inside.
अजय जी हमारी campaign है बार-बार पूछो. So we have listed some conditions. We have added one today is abortions. We have a condition like person will not tell on the first visit मैं cigarette पीता हूँ कि नहीं पीता. बार-बार पूछो. On an average, sometimes 5th and 6th time the person asks. So there are like sexual preferences, like sexual histories, like so depression. So बार-बार पूछो campaign में आज हम abortion पर डाल देते हैं. First time history of abortion patient may not give you on the first instance. You repeatedly ask.
Yeah. History of STDs. Sexually transmitted diseases.
Sexual behavior.
Yeah.
That also will not come on the first time.
They will never tell
They
you
will never
that.
tell you.
So,
तो अबॉर्शन में 2 इश्यूज है ना, एक तो आपका स्पॉन्टेनियस है and then
that is not under control.
one is
but-
induced. But
Induced.
generally, spontaneous abortion is quite common, So I think that has to be differentiated and its relevance
Yeah.
has to be understood.
It has to
No,
be covered
Because
by
what we are trying to understand is the relevance of induced abortion, instrumentation, linkages with the sepsis.
No, I want to come back when we're talking about sepsis. What about infection in the first trimester?
Infections in the first trimester as such patient would not have if she is not having fever, but asymptomatic bacteriuria is common in pregnancy, which
No,
is
fever
not,
in the first trimester. Fever in the first trimester in pregnancy.
why she should have fever?
I said, if there is a fever,
If there is a fever, then we have to investigate before any.
don't ignore
investigation.
fever in the first
Yeah,
trimester.
yeah.
So I can tell you one case recently, one of my own family, close family friends. At 14th week, the mother showed to 4 doctors, and she says, "I'm having fever, I'm having rash." I saw the paper. I saw the paper where she has written, "On this day, I'm having rash, I'm having fever, and I'm having a lymph node here."
Oh God. So she was
Rubella.
rubella.
Ignored. 4 doctors said nothing. Now she is born with, the child is born with congenital rubella syndrome.
They could have tested actually, IgM and
See, सोचना पड़ता है
First
उसके लिए।
trimester.
सोचा ही नहीं, 4 doctors, including ENT, including gynae, including physician, 4 doctors saw her. Every time she went, she says, "There is a fever," all in Delhi. She went to top hospitals, top doctors. Fever. I saw the paper. She's written in the paper. She took that paper with her. And she said all the time, यहाँ पे मेरे को यहाँ gland है. Classical rubella. Now the child has bilateral cataract, he has hydrocele, hernia, PDA, pulmonary stenosis, and whatnot. And you know what do they say? I mean, this is nothing but abstract. The hospital says, मरने दो, ले जाओ.
बच्चे को
Now the child has got, I got him PDA ligated, I got hernia operated, now congenital cataract we tried to overcome.
First
So
trimester
therefore-
fever is of course it is
Very
very important.
significant.
No, should not have normally. If she has, then there are various repercussions. Whether to go for abortion, whether to go for her treatment, but main maternal life also is at risk sometimes. Already focus of infection is there, and then pregnancy is changing the immunity of the patient itself. So she can have more chances of mortality also, not because of rubella, I mean, but
Okay. Immunization.
If you
Immunization. Quickly, start the immunization. Start from.
नहीं मैं पहले एक जो बात बताना चाह रहा था
since you are talking
you know,
about
you're talking
immunization,
about one
rubella every child adolescent must have.
Therefore, I'm starting
Right.
the whole in the resolution. लेके सब कुछ start
मेरे
करें.
को लगा कि पहले जो एक इम्पोर्टेंट बात है कर रहे थे आई थॉट सप्लीमेंटिंग because it has linkages with the program because we are proposing and propagating the concept of institutional delivery
Institutional.
जैसे अभी हमारी कंट्री में as per available data sets around 80% deliveries in the country I'm talking about country as a whole I'm not talking about Delhi 80% deliveries are happening in the institutions so that means there is a sea change but still 20% are still happening the home deliveries are happening and there could be geographical places where 40% will be home 60% will be institution so the message what I'm trying to give here is that under the government of India's MCH program there is a provision to provide free transportation to every pregnant woman and there is a call center approach. They just have to give a call center 108 and then the ambulance will reach at their residence and will take the mother to the hospital. So I think if all the practicing doctors they are aware of that there is a system, there is a provision because providing free transport to the mother is one kind of intervention which the government of India is proposing because everybody can't go to a private hospital for delivery. There are a large number of people who avail government hospital facility, but sometimes transport availability becomes an issue. So that's one point I thought of adding at this point of time. And the second important thing, as I am trying to keep that focus in mind that we are talking to the audience as a practicing doctors. Another important aspect is in every pregnant woman identifying high risk and so on and so forth. Then there is something called as the birth preparedness. This is a very, very weak area. Nobody discusses with the mother in terms of, we call it micro planning, birth preparedness. This has remained as a theoretical concept, but if you try to put into practice, the benefits will be very high, very high. If mother says, मेरे घर में 4 बच्चे हैं, मैं तो जा ही नहीं सकती हूँ, तो then one has to think in some other way. कि A&M को बोलना है घर में डिलीवरी करनी है उसके तो या उसको बताएंगे कि फ्री ट्रांसपोर्ट अवेलेबल है शी कैन अवेल द फैसिलिटी तो बर्थ प्रिपेयर्डनेस इज अ वेरी वेरी इंपॉर्टेंट एलिमेंट एंड शी मस्ट नो एवरीथिंग इज फ्री बिकॉज मेनी ऑफ द मदर्स दे आर अफ्रेड टू गो टू हॉस्पिटल कि मैं जाऊंगी वहाँ बोलेंगे ये ग्लव लेके आओ ये ड्रिप लेके आओ ये इंजेक्शन लेके आओ वहाँ बिल आ जाएगा 2-4-5 हज़ार विच शी वोंट बी एबल टू अफोर्ड तो अभी क्योंकि गवर्नमेंट ऑफ इंडिया का जो प्रोग्राम है जिसको बोलते हैं JSS के प्रोग्राम जननी शिशु सुरक्षा कार्यक्रम इसमें in that program the government is committed to provide absolutely free of cost and if you report any matter that somebody is charging we will can take action and accordingly all the hospitals in the country are being provided funds to implement that program तो ये मैंने कहा बता दूंगा और तीसरी जो important बात है beside birth preparedness there is something called as counseling for breastfeeding somehow एक जो लोगों के दिमाग में रहता है कि जो ब्रेस्ट फीडिंग वो तो पीडियाट्रिशियन करेगा एंड आई थिंक इट इज द राइट टाइम ड्यूरिंग प्रेगनेंसी वी मस्ट इन्वेस्ट मे बी फ्यू मिनट्स इन टर्म्स ऑफ टेलिंग द मदर दैट ब्रेस्ट मिल्क इज द बेस्ट एंड मस्ट प्रपोज आई मीन प्रमोट इट डू सम काउंसलिंग आल्सो कि क्या फायदे होते हैं बच्चे का दिमाग बढ़ता है जैसे अभी जो रिसेंट स्टडी बताती हैं कि इफ द चाइल्ड इज ब्रेस्ट फेड इवन द आईक्यू ऑफ द चाइल्ड इज मच बेटर in terms of illnesses episodes, mortality episodes, बच्चा बीमार नहीं होता है दिमाग अच्छा होता है उसका तो थोड़ा सा they can spend some time on promoting breastfeeding that is going to be the very good so that's the second point और तीसरा जो point है जब मतलब pregnancy के time पे ये भी हम देखते हैं कि something like family planning which is called as the postpartum IUCD or postpartum sterilization I think one must start doing some kind of a counseling at that point कि तुम्हारा अगला प्लान क्या है अभी बच्चा तो हो जाएगा आगे क्या प्लान है आपका क्या सोचा आपने तो एटलीस्ट यू कैन इन्फॉर्म द मदर की भी कॉपर्टी लगवा सकते हो आप एंड वी हैव द सिस्टम और यू वांट टू गो फॉर स्टेरिलाइजेशन देयर इज अ सिस्टम तो आई थिंक सम डायलॉग अराउंड इट इज आल्सो इंपॉर्टेंट आई एम कीपिंग इन माइंड नॉट द अर्बन हाई क्लास पीपल यू टॉकिंग अबाउट रूरल एरियाज पुअर इलिटरेट मदर्स उसको मालूम ही नहीं है यदि आप उसके ऊपर बताओगे पूछोगे तो सिनेरियो में चेंज वैसे वी आर स्ट्रगलिंग टू इन टर्म्स ऑफ ब्रेस्ट फीडिंग रेट्स हमारे कंट्री में हाल ही है अभी कि 40% of the children, newborns, there is early breastfeeding happens. 40%, 60% do not get that opportunity. क्योंकि हम ज़्यादा उसमें ध्यान नहीं दे रहे हैं उसको, ना मोटिवेट कर रहे हैं मतलब. So there are kind of a lot of misconceptions around it.
हमने प्राइवेट सेक्टर के लिए जो IMA की पॉलिसी है, and which we have interviewed a lot of people, mothers, and because at that particular moment, when the delivery takes place, on that day they decide who pediatrician will come, which pediatrician will come. May not be on call. Maybe the junior most pediatrician on call on that particular day. Suppose the mother is busy with episiotomy, busy with control of the hemorrhage. Invariably the colostoms counseling gets missed. So what we are now talking about is that involve pediatrician in 9th month. Select your pediatrician. I'm not talking about government. I'm talking about private sector. Involve pediatrician in 9th month. Visit him. He gives you. He is the one. Hire him a month before the delivery, so that he gives you all counseling and takes care at the time of delivery. So that he's a part of. So that he is a part of the team when the delivery takes place. That's our.
That is the idea.
99999. This is what we are.
I feel the gynecologist also who is attending the.
Anyway, they will do, but there is one pediatrician also. Normally, what happens is in my hospital, they start looking for at the time of delivery. Okay, आज किसकी call है? आज किसकी call है? इसको बुला लो. Why? The pediatrician should be involved much before.
Yes.
Even if they are admitted a day before, the pediatrician is not involved. He is involved after the delivery. If you involve the pediatrician before delivery, it's better. And secondly, we are insisting on father's involvement. Father should be a part of the delivery. As a policy, IMA is trying to promote these two things.
और दूसरा जो कॉन्सेप्ट होता है जो हम उसको भी हम आजकल इग्नोर कर रहे हैं इन द मॉडर्न वर्ल्ड, समथिंग कॉल्ड एज रूमिंग इन. यू नो द न्यू बॉर्न हैज टू बी नियर टू द मदर. अभी क्या हो रहा है, बिकॉज ऑफ न्यू इक्विपमेंट विच हैव कम, आपका रेडिएंट वार्मर आ गया है. देयर इज अ टेंडेंसी टू पुट मदर ऑन ए सेपरेट बेड, द न्यू बॉर्न ऑन ए सेपरेट बेड. You know that is a disconnect between the mother and the newborn. So the newborn has to be with the mother, because that will promote not only kind of binding with the mother, physical, psychological.
What is the current MMR? What is the
current MMR in the country is 167 per 100,000 live births, which roughly converts into 45,000 mothers are dying every year, which could have been prevented.
And what about IMR?
IMR we have as of today is 37 per 1,000 live births, which converts into around 1.2 million, 12 lakh infants are dying every year, which could have been prevented.
So these are preventable deaths.
The largely preventable. I would say because हमारा 37 है. If you look at Bangladesh, they have उनका हो गया 20 हो गया, and maybe if you Japan and US, उनका under 10 है.
I'm only going to talk back is what IMA is. I'm going to link it to what IMA is doing. IMA campaign is every preventable death should be audited by the doctors of that locality. Where did we make a mistake? Akidwara now. So unless we do that, every preventable death should be audited by the local doctors to find out what was the factor which led to death, so that it doesn't happen again.
Try to identify avoidable reasons,
Preventable death.
Transport नहीं हुआ.
I'm talking about every.
There could be no social system problem also. It is not only that it is always medical negligence.
Negligence की बात ही नहीं कर रहा.
System में भी हो सकते हैं ना मतलब.
It can be delayed diagnosis, delayed presentation. But then somebody.
Mother ने delay कर दिया मतलब. She was waiting for her husband to come and then she.
But then message has to go.
So delays has to be avoided. Avoidable.
No, what I would say is जो MBBS doctors who are taking care of mothers at a remote area would do well if they know the mother's prior. I mean, first trimester, let us talk about antenatal care, minimum 4 to 5 visits, which hardly any patients have. They have only 2 or 3 visits, 1 visit. So 5 visits are must first, as early as possible in the first trimester. And 3 spread out in the rest of the 3 trimester or 4. In Western world, they say 4, total 4 visits. In India, we say total 5 visits. If the patient doesn't have these visits, it is impossible to label her as high risk or low risk because you will miss. So doctors first of all have to see that the mothers come to them regularly If there is no specialist available in the remote areas particularly, they are the first point of looking at the patients. So they are more responsible. They have to, like we said earlier, high risk, they have to segregate and send them to a higher level. That one thing they must do. Second is giving prophylactic iron tablets. Third is detecting hypertension. Fourth is detecting sepsis. Just ask the patient whether you have
urine albumin.
Urine albumin. Every time the patient comes, we generally do the hemoglobin monthly at least in all patients, and urine albumin sugar to detect preeclampsia, and in case microscopic also should be done if possible the first move. So that asymptomatic bacteriuria is one of the causes of preterm labors. So we are not doing it mandatorily, but if possible should be done. So also blood sugars, DIPSI, you know about DIPSI, that the patient may not be fasting. You take one sample, and that is after 1 hour of whatever she eats, 1 hour after, take a blood sample. If it is higher than 140, patient should be treated then further treated. This can be done, DIPSI, at the primary center level, or if there are no specialists available, this much can be done by the MBBS doctor. And then immunization, like you said, patient should have had MMR earlier in life, so that rubella is taken care of. There are no problems in the baby.
During pregnancy.
And during pregnancy, only tetanus toxoid. That is from 16 weeks onwards, anytime, 2 injections at the interval of 1 month. And if the patient has taken earlier, within 3 years, if she has second birth, then there is only 1 dose required.
Now the government is thinking of changing it to TT. यहाँ पे tetanus ये पे हो, not TT.
Tetanus toxoid.
Tetanus with from TT to TD. Government something.
वो तो उसके लिए बच्चों के लिए
not with pregnancy. Pregnancy it is pure TT.
Yeah.
तो डिप्थीरिया का प्रेवलेंस नोटिस हुआ है ना थोड़ा हायर एज ग्रुप में.
तो हम प्योर TT की बात कर रहे हैं, तो रेशियल इसमें लगाना है.
So, and then if they are high risk, they should be referred in time to the higher centers or your specialists if they are available in the private practice.
ये आपका जो 6,000 रुपया है प्रेगनेंसी वाला, हाई रिस्क भी ज़्यादा है.
This is
for all.
Across the board.
This is for all.
Who reports to the institutions, and there are some 2 conditions have been put. One is the delivery has to happen in the institution, and second is the child has to be fully immunized.
And there is, I think, one more condition. This is only for first 2 children. If the number is third,
अभी जो है
fourth,
उसके बारे में भी ना डिस्कशन are happening.
it's not for all.
वो GS भाई था ना हमारा पर
600 का.
नहीं वो उसका वजह होता अभी this is something regarding Food Security Act,
6,000 for every.
pregnant, irrespective of the
There's another scheme for Ladli and kangaroo. We were talking of care during birth. So care during birth and kangaroo mother care. These 2 things are now coming up. Care around birth, CAB, where the women are given special care. They are put on pedestal kind of, and I mean that she becomes the center of all care. If that is given by the practitioner, whoever is there, then the maternal mortality will be less. That means institutional delivery. That means no home deliveries. And the pediatrician and the anesthesiologist, blood, everything should be available. And kangaroo mother care is about you were talking instead of putting the baby in the crib.
Before the cord is cut, you can put it on the mother's
chest and the skin to skin contact.
And if there is a preterm, you can use it as your daily basis.
Yeah. So these 2 things have come up recently, but they were there initially also. Now they are in focus.
Anything else in antenatal care?
I said about visits, when, how, whom should be given. When, I told you, at least 5 visits, and more if they are high risk. So, if they are high risk, patients are going to be treated by a rural person. Patient
I have one point, slightly away from your policies in private sector. Why 5 visits?
Why?
Why 5 visits? Why not monthly visits?
No, this is minimum.
So 9 can happen.
Yeah.
So we will private sector will promote 9
This
visits.
is minimum. I'm
No.
talking about minimum.
We are promoting 9. On the 9th of every month you go. You're a doctor.
Yeah.
It's easier.
Absolutely.
Why should we say 5? Because then we send our car every 3 months for servicing. Now you have 2 cars, the mother and the baby.
No, the problem about this is the mother does not want to go to the doctors at all.
I said, see, in the private sector we should promote that the chances of care becomes higher if you go every month.
Yeah.
So let us tell me antenatal clinic, every gynecologist will have say 30 patients. Let it be at...
No, properly booked patient gets about 12 visits. Because in the last trimester they are supposed to show after 36 weeks each week.
एक week
We are talking about
9 visit count करें ना.
no, 9th को हर महीने जाना उसके बाद में and as and when required by your gynecologist. It becomes easier. Now the campaign becomes easier कि 9 महीने में आपको जाना है कि 9th आगे जाना है 9th के आसपास जाओ.
Yes, you are right.
So इससे क्या होगा कि and there are आज की डेट में educated society है, they want to know about it.
More frequently in the last trimester, I would say. After 28 weeks, it should be 2 weekly, and after 36 weeks, it should be 1 weekly.
Weekly जो है. Anything, any other project? What about
अब
your?
दूसरा मैं before we start with immunization, because we are talking about mother, so something very critical is regarding newborn. Because newborn is again a very neglected area. Because most of these MBBS doctors, they have not been taught about newborn. Because neonatology is a new discipline. And particularly the doctors who have done the MBBS maybe 10-15 years back. And many of them are in practice. Now in terms of, because we set a target, we set 12 lakh infants dying every year. और इसका जो further आप disaggregate करेंगे, the interesting finding is 9 lakhs out of these 12 lakhs are newborn or neonatal period. मतलब पहले महीने में मर जाते हैं आपके. That means if something has to be done for IMR, you have to do newborn को तो करना ही करना है. अब newborn को how to pay attention to newborn. एक तो मैंने बताया कि 70% of my infant mortality is contributed in the first 1 month of life. Now how to provide best of care to that 1 month period. Now इस 1 month के भी period में maximum 50% of these deaths happen on the right on the day 1. बच्चा born हुआ in unsafe hand, untrained people, and then the child dies of asphyxia. Asphyxia और newborn की death के 3 major reason है. 30% die of asphyxia, 30% die of sepsis, 30% die of prematurity. मतलब 3 important बातें हैं जो ध्यान करनी है हमारे. बाकी 10% you can take congenital, diseases and so on. So now how to address prematurity, how to address asphyxia, how to address sepsis. I think we need to equip our healthcare providers in the art of managing these 3 things. Then majority of the newborn deaths could have been prevented or avoided. और जैसे प्री टर्म जैसे बोलते हैं हमारी कंट्री में कोई 15 से 20% जो डिलीवरीज है वो प्री टर्म होती हैं. अब कहते हैं हमारी कंट्री में 26 मिलियन 26 मिलियन बर्थ हैपन, तो उसका लगा लीजिए आप उसमें से 15% जो है आपके रफली हो गया आपका 2.6 प्लस 1.3 4 मिलियन डिलीवरीज जो हमारी प्री टर्म हो रही हैं. अब नाउ द आर्ट ऑफ ए डॉक्टर इज दैट हाउ टू आइडेंटिफाई दैट प्री टर्म लेबर. अब वो डायग्नोसिस करनी है आपको कि जो मदर है शी कम्स एट लेट्स से 32 वीक्स, इसे मुझे पेट में दर्द हो रही है. नो यू हैव टू आइडेंटिफाई इट इज अ ट्रू लेबर पेन और अ फॉल्स लेबर पेन. So there are clinical criteria which madam will be able to explain further कि आपको आइडेंटिफाई करना है प्री टर्म लेबर. और यदि आप प्री टर्म लेबर आइडेंटिफाई कर लेंगे तो then there is something called as the antenatal corticosteroid, which is a well known strategy used by pediatricians, used by experts. वो मदर को दे देते हैं and it is absolutely safe for giving it to the mother, but many of these practicing doctor might have apprehension. होता ना वो steroid apprehension कि भी steroid नहीं देना, माँ को दे देंगे पता नहीं क्या होगा. But this is a very well known strategy which helps in reducing that premature जो बच्चा होता है उसका lung gets mature and the probability of dying of that child reduces. तो एक तो मतलब promoting the concept of antenatal corticosteroid by diagnosing preterm labor well in time.
And what time? You had at what?
After 28 weeks anytime, if the patient goes to labor, it is not useful before that. So what he is saying is right. The two things are connected. Anemia is one biggest cause of preterm labor and low birth weight baby. So all these factors, that poverty, illiteracy, lack of education and personal hygiene, these factors are responsible for patient going in preterm labor. There is no direct cause till now found of preterm labor. So control of medical disorders is second. The first was personal hygiene, poverty, illiteracy, awareness. This has to be told to the patient when she becomes pregnant that if you leak or if you have a vaginal discharge, there are many even educated patients like you said, they come with already it is too late, they have leaked, they don't know because the doctor has not told. This should not happen. Any excessive discharge per vagina, if non-pregnant state or early pregnancy should be treated. One thing, anemia should be corrected. These factors will go in preventing preterm labor to some extent. Preterm labor as such, we don't know the cause, but it is exaggerated or it is precipitated by these factors like anemia. Low birth weight is because of anemia. Preterm also is because of anemia, and then there is a role of infections, like I said.
Infection will come back apart from steroid.
तो एक तो रहा स्टेरॉइड, दूसरा जो प्रीटर्म बच्चे होते हैं उनको मैनेजमेंट करने के, बिकॉज जनरली दीज प्रीटर्म चिल्ड्रन डाई ऑफ हाइपोथर्मी, दे डाई ऑफ हाइपोग्लाइसेमिया. प्रीटर्म क्यों मरते हैं, मतलब उनका जैसे लंग्स जो होते हैं मैच्योर नहीं होते हैं, तो स्टेरॉइड्स हेल्प्स इन मेकिंग देयर लंग्स मैच्योर. So you have taken care of the lungs by giving steroids, but what about the other needs? Because generally preterm child is also a low birth weight baby. This child even cannot suck, the milk, breast milk. So then maybe that child might require kind of a feeding with the spoon, some kind of. So there are special guidelines are available. Hypothermia को manage करने के लिए basically जो concept है कि child should not be exposed to cold, So warmth has to be provided to a child. And I think the mother is the best, I think, warmer for a child.
And
Absolutely. And hypoglycemia के लिए भी उसको feeding करना है बच्चे को. और बच्चा breast feeding कर नहीं रहा है, तो आपको उसको mother का breast feed extract करके भी that can be kept and that can be given.
what about sepsis?
अच्छा दूसरी जो
Like we said, three causes which are interconnected: mother and the child. Like mother is infected, the baby is going to have septicemia. Mother is having preterm labor, baby will be preterm and dying. These two are major. And third is, like he said, birth asphyxia. Birth asphyxia is the biggest cause besides these two. So birth asphyxia we can avoid by having a good delivery at a proper time, term. So to achieve that, the control of medical disorders and antenatal care play a very important
And birth resuscitation.
Yes. And then
birth resuscitation.
yes, attending to.
What about gentamicin, which we give it to?
अच्छा दूसरा मैंने रीजन बताया आपको, सेप्सिस से बहुत न्यूबॉर्न मरते हैं. Obviously, sepsis has to be avoided by using all hygienic measures. Mother must wash her hands, but in terms of there are kind of a typical red flags when to identify a newborn with sepsis. The newborn stops taking feed. Child might be having hypothermia. Child might be having fever. So there are clinical pointers are there, and in case of a suspicion of sepsis, there is a role of an injectable antibiotics. An injection gentamicin and oral amoxicillin combination, which is being talked about, at least at the peripheral level, it should be given, and it has been found to be very effective in terms of reducing mortality due to sepsis in newborns. Injection gentamicin.
This week can be given by the primary care
Yes,
worker.
दे सकते हैं, उन्हें भी दे सकते हैं.
They can give gentamicin and they can start.
बाकी बच्चे को जो फीडिंग करनी होती है वो चम्मच से करनी है, उसको मदर का मिल्क एक्सट्रैक्ट करके देना है, मतलब instead of promoting kind of a top feeding with bottle feed or using dabba का दूध, mother's milk can be given.
Before we sum up antenatal care, let's just talk about deworming or tomorrow's.
Deworming is a kind of a new strategy which the government of India has started, which talks about a single day strategy of giving deworming albendazole tablet to all the children from 1 to 19 years of age. And what we are saying is, this particular campaign, we are proposing to reach around 340 million, 34 crore children. That is the target which has been set. Now this is for the first time in this particular round. This is the third year of the campaign. In this particular round, around 7 crore children are also being targeted even in the private schools. In our initial campaign, we were focusing only on government schools and the government aided schools, but the private schools were not catered. But this is for the first time we have also taken up kind of initiative with the private school, and the private schools have come forward in terms of giving their children albendazole tablet. So that's one. Now the second important thing is that obviously the children will come in the school or in the Anganwadis and will receive the tablet. But sometime important message for a practitioner is that many of these children, they might get some kind of a side effect in the form of a mild nausea, mild vomiting. But generally what happens, particularly in a school setting, where the adolescent children are given tablets, the one child gets vomiting, there is a hysteric attack in the group of all the children. And this has been very well reported, And then the whole program gets a very, very big slap unnecessarily. At that point of time, there should not be any panicking, because albendazole is absolutely a safe drug which can be given to children without any side effect. But mild side effect, they are all manageable. And it is also been seen that children who have a very high load of worm infestation, they might have more of a side effects. And then beside that, Government of India has also come up with a adverse event monitoring system. There are around 210 monitoring centers all over the country. And I can share with you the so-called the hotline number is there. Toll-free number is there. Anybody can contact them.
Are we giving chewable or non-chewable?
This is a chewable tablet.
Chewable tablet.
Chewable tablet.
So it's not just chew it.
Just chew it. और इसी बारे में बोला कि साइड इफेक्ट के बारे में sometime people may report back to practitioners, and they should be able to reassure the family members and the community that there is no cause of worry, in terms of mild side effects, because they are kind of controlled by itself.
And why only once in a year?
Once in a year, nahi, actually, to be very frank, this is a new initiative which the Government of India has done. Is now we have recently completed mapping of worms infestation in the country. Now I know what is the prevalence of worms infestation in state A, state B, state C. Now accordingly the range varies from 18% to 85%. And now state like Tamil Nadu has a prevalence of 84%, Sikkim has a prevalence of 89%, and particularly the northeastern belt, the prevalence is very high. And the reasons are, and
85% of the community has worms.
85% of children, because the testing is done in children. And if children have, the adult might have. This is the prevalence, and the stool samples have been tested. And worm infestation has a very, very close relationship with the, the so-called ecology. Particularly the areas which are moist, humid, this prevalence has been found to be very high. In places where we find prevalence to be more than 20% in a population, we are recommending, 2 rounds of deworming. First round happens on 10th of February. Another round will happen on 10th of August. These dates are fixed actually. And then only 2 states are left. One is the Rajasthan, another is Madhya Pradesh, where the prevalence reported is around 18% and 19%, less than 20%. So they are going for an annual round. Otherwise, whole of the country will go for a biannual round.
And Delhi?
Delhi also biannual round.
I would like to say something before we come to any. We have only covered till now first and second trimester. Third trimester we have not touched at all. So ultrasound for knowing the antenatal anomalies, knowing the IUGR, knowing the placental localization. Ultrasound is not mandatory in each patient but advisable, particularly in a primary gravida. And particularly in those patients where there are medical disorders, there are other problems like expected low, IUGR, fetal growth restriction. These things should be actually detected by first center level. MBBS doctor should be able to know that there is a fetal growth restriction, and then the patient should be referred. Like we say to ANMs also, or nurses who are doing, same is the case of MBBS doctor, should detect some of the things like preterm labor, history of all these things. Patient should be referred to a further center. And we have not talked about blood grouping and RH typing, which is a must in all patients. And any center where the delivery is occurring within a half an hour's distance, there should be a higher level center for the transport of the woman, because today the patient is labeled as normal or low risk. She immediately becomes high risk if there is PPH. She dies of PPH simply. So it is I think MBBS doctor can help in this, that particular area, 2-3 kilometers, one blood bank or some reserve of blood transfusion, blood bank, if he can help, should be available. So also the anesthetist, and so also the resuscitation should be done by the GP if he can. Because patient labeled low risk will be anytime high risk during labor. So we have not taken into account this factor at all. We say that home delivery, or that is why institutional deliveries are recommended now. That home delivery itself, पहले तो करते थे कि traditional birth assistant can deliver, but it is not so. Septicemia and hemorrhage is not controlled by these methods. So institutional delivery should be there, where other facilities should be there.
I have a few comments and questions also. I was a chairman of health in Municipal Corporation of Delhi for 5 years, 2007 to 2012. School health program, maternity programs, and everything we were taking care of. We did a survey of school children, MCD school children, from 1st to 5th. And 80%, we did hemoglobin estimation as such. 80+% of people were having anemia by my standard, 12.5 WHO standard. And at that time in 2007, we started deworming twice a year in MCD schools, and iron folic supplementation every Wednesday. The child will be given along with the midday meal. He'll get the midday meal in front of the teacher. The teacher will give the tablet, eat the tablet first, and then give it to every child. That system, in fact, was started while I was the chairman.
Okay, good.
Number 2 was maternity homes in Delhi. We have around 33 maternity homes in Delhi under MCD.
Yes.
But the biggest problem is the infrastructure and manpower. Talking is okay, government may be talking anything, even I was talking that time. But if, there is a maternity home, there is only one doctor. In most of the maternity homes in Delhi, there is only one doctor on 24-hour duty. She lives away from the center. There is one Asha worker or ANM, whatever, there, 24 hours a day. Where there is ambulance, there is no driver. When there is a driver, there is no ambulance, no anesthetist, no pediatrician. And she is the lone doctor there in Delhi. And I'm sure the situation must have been changed by now. Because government schools.
जो आप बोल रहे हैं actually, you're talking about 2007.
Well,
अब मैं बात कर रहा हूँ 2016-17 में. पिछले 5 साल में मैं बोलूँगा.
maybe.
There has been a new program which is a JSSK program. It is a new arrival in the system. अब आप पूरे देश में कहीं भी जाइए, आपको एम्बुलेंस नजर आएंगी करती हुई, and mother will call within half an hour. Mother will get an ambulance. That's the situation. There has been a lot of sea change. I will not say that everything has changed.
But still, I think a lot has to be
But
done.
Delhi is a very, very unique case actually. It is not a case which can be exemplified to generalize the things for
Maybe.
whole of India. Delhi is a little exceptional.
In Delhi,
multiplicity
anemia
of
has
agencies
reduced.
and,
That I can say.
Must have.
Because
10 years
we are
ago.
getting less of anemia, severe anemia patients in labor. But outside, I am not sure. Outside
At
Delhi.
that time, we took the help of Nutrition Foundation of India, WHO, and UNICEF. All these things.
बड़ा अच्छा किया आपने जो this.
बहुत जबरदस्त.
This is a great. This is still continuing.
And in case you want, I can give you the document.
अभी चल रहा है कि नहीं folic acid is still
It
continuing.
is still continuing. We have a comment from our specialist. Pregnancy hypertension, avoid ACE inhibitors. Enalapril can cause congenital renal dysplasia.
ACE
So,
inhibitors are contraindicated.
yes, very much
Totally.
contraindicated.
Totally.
And avoid NSAID also, they can cause congenital
Yes,
anomalies.
yes,
Then pregnancy, examination of breast for inverted nipples. That I think
I
we
said we have not covered third
Yes,
trimester.
yes.
There's a couple of comments which have come on the SMS.
चलो वो
And
So I have said that
then
already.
HIV and hepatitis B in
Yes,
pregnant
that's
mothers.
advisable, not mandatory. Not
I
mandatory.
think we should tell our doctors at least if they can do it, they must do it.
Yeah, it is not mandatory till now, but HIV yes and hepatitis B, and
Mhm.
I would say hepatitis C also. E, C, because
If
we
you
are
do
getting
it better.
even, yeah.
And
Even talking about HIV of the spouse, not only
Yes,
the
yes,
lady,
yes.
but also the spouse.
What is advisable and what is mandatory? We have talked about only mandatory things.
and
There are
another
many other
suggestion is
things.
that after 3 months of age, give full iron supplementation
Yes.
till 1 year of age. What is your comment on this?
1 year of what
The
age?
child.
Yeah, because the iron stores are not complete till then. But because the mother is given from the second trimester onwards, it will help the child to have
Better.
better.
जो हमारे प्रोग्राम में है ना वैसे वो 6 महीने के बाद में है, 3 महीने में नहीं.
In,
आपने बोला तो अभी भी
And
लोग
mother's milk
But as
unfortunately
per the
doesn't
program,
have
6 months.
iron, so
नहीं.
it has to be given. That is one thing. Even if breastfed children will have to be given iron.
So let me sum up. So we have two experts with us, Dr. Anjali Tanpe and Dr. Ajay Khera, and with me, Dr. V.K. Monga. One message is very clear is that we are talking about national health program, we are talking about mother and child care, we are talking about adolescent care. IMA is only concerned about preventable deaths. In today's era, 2017, why should any preventable death occur? We are not short of doctors. We still have 10 lakhs doctors who have MBBS. Our job should be that every preventable death should be audited and we should be able to avoid these types of deaths, whether they are IMR, whether they are neonatal death, whether they are maternal mortality, in fact anything. हमेशा अपने आप से पूछो, वो तो ठीक है, लेकिन मरा क्यों? Unless you ask that, you say, बच्चा से डिलीवरी में मदर मर गई, लेकिन मरी क्यों? PPH से मदर मर गई, लेकिन PPH हुआ क्यों? Everywhere you ask a question, so that you will be able to prevent the second death. That's what our main objective is. IMA shortly is going to come out with a primary for GPs, a performer where all national programs, tips will be included. Our objective is that we should be the best family physician concept, to bring family physician concept back in the circulation and reduce maternal mortality. IMA is against reducing maternal mortality from 167 to 125. IMA's aim as a doctor should be 0. We should aim at 0, then only you will be able to achieve what the government wants. Otherwise, you are happy, okay, koi baat nahi, ek mar gaya. So in every death, we should ask ourselves, why did the child die? That's all for today. Let's thank Dr. Ajay Khera and Madam Anjali Tanpe to be here with us. And we will be back next Thursday with another program. Till that, me and Dr. V.K. Monga say goodbye to you. We'll be back. And we thank, in today's program, we got a grant from Johnson & Johnson, who are with us in our academic activities, monthly activities we are doing with them, and none of our contents today were influenced by them. This is an independent discussion, though supported by an educational grant. Thank you very much.
Thank you, sir.
Thank you very much. Thank you. Good.